Uh, Welcome back again, and thank you for being here. I'm glad to be chairing the first panel on the Transnational Conference on the Sexual Reproductive Health and Rights. I'm even happier to have five excellent panelists with us. I'm gonna start with Ms. Ilyana Malouk, who is a development practitioner working in the field of civic activism, youth empowerment, and social cohesion. She's managing currently the governance program with Oxfam in Lebanon, a pillar that focuses on advancing the rights of the most affected groups, including women and youth, through capacity building, education, and advocacy, influencing work, support to local leadership, and strengthening of civil society groups and organizations. Ilyana, please.
Good morning, everyone. Thanks for having me, and thank you, Dr. Faysal, for a very comprehensive introduction in the morning. And very informative opening remarks. I think we all, or at least I learned a lot from them. I'll be very brief and maybe introduce a bit some of the most prominent findings from a very recent baseline study we conducted in Tripoli, one of the marginalized cities of Lebanon. And this study was a youth-focused study, but before I do that, I'll just introduce Oxfam very quickly and the work we do in Lebanon. So Oxfam, of course, is a rights-based organization. We have been active, or we existed since 1942. In Lebanon specifically, we are here since 1993, doing relief work, but also humanitarian advocacy, policy influencing, governance, economic justice, and gender justice focused work. On the study, this study was led by external experts specialized in the field of sexual rights and health, but also led at the field level by youth. So all the animators, data collection people, and the teams that supported to a certain extent the analysis were youth at Tripoli. The study was conducted last year in 2021 and looked at bodily autonomy, or the extent to which women and adolescent girls and youth in Tripoli report positive or constructive bodily autonomy. 2 or 3 findings from the study, not to go through the research results now. I want to highlight that 89% of adolescent girls interviewed in Tripoli, and the methodology was scientific, and the results are statistically significant. 89% of them reported limited, if not non-existent, bodily autonomy in Tripoli, and 75% reported limited ability to provide for their sexual health and rights in Tripoli. And around those findings, we also note very interesting qualitative observations. One of them might be especially interesting for you, Dr. Kak, because you touched upon the role of the healthcare service providers and their positive or negative role they can play. In Tripoli specifically, many of the interviewed adolescent girls and women reported that the healthcare service providers are causing even more limitations and putting even more burdens on their ability to make choices regarding their sexual rights and sexuality overall. One example I remember very quickly very clearly, sorry, from the findings is that when it comes to deciding on methods of contraceptions, healthcare service providers are asking for the consent of the male partner or husband or a caregiver for the adolescent girl to consent to provision of any prescription or any actual contraceptive material that girls and women could use. So who decides on behalf of adolescent girls and women in Tripoli? It's not the girl herself, neither the woman herself. In many cases, it is the healthcare service provider. It is the male person available within the family, a father, a husband, a brother, a mother, right? A religious leader, a community leader, a family leader that has a power, right? And the family, all of these people were reported as key influential actors affecting the quality of life overall of women and adolescent girls in Tripoli. Of course, we're not new to these observations and these findings, but what's surprising is that 89% of those girls and women feel this way. And this is happening regardless, in our study at least, of the socioeconomic and educational level of women and girls. This is mostly happening because of the traditional social norms and beliefs that in many cases, higher educational level and better socioeconomic status are not able to beat them, are not able to beat social norms. So attitudes and behaviors are key factors and key elements shaping positive, sexuality of women and girls, or the absence of positive sexuality of women and girls. Also, girls themselves, with the lack of awareness of, what positive sexuality and constructive sexual health and rights look like is another factor. Hence the importance of all educational and awareness raising programs that many actors in the field try to promote and resource for. Caregivers' own experience in SRHR is also another factor. So women or female caregivers have their own experience, and they project those experiences when they raise, right, their children. Of course, the level and extent and also type of engagement we allow or we promote for male caregivers is also another factor. Hence the importance of engaging males not only, as partners, but also as main actors receiving support themselves and working towards shifting their attitudes as well, not only supporting participation of women or consenting a better access to sexual rights and health for women and adolescent girls. Safe spaces are important to promote dialogue among all of these actors that affect the ecosystem of women and girls and their access to sexual health and rights. So safe spaces also do not exist because the topic still a taboo in Tripoli and also other areas. So we want, as you said in the beginning, in the morning, to try to normalize speaking about the topics, expressing about, own's feeling, own's preferences, own's pleasures, and so on. So that's why Oxfam also, as part of the Masaruna and also other projects, the Power to Choose that my team is representing today, are trying to create the safe spaces that bring together all of these actors, including religious and community leaders, hopefully, to discuss similar topics and try to normalize the rights, I would say. We're not normalizing with the topic, we're normalizing with creating a lobby around those rights. These are universal rights of not only women and girls, but also other gender minorities, including the LGBTQI community. I'll stop here for now. And yeah, maybe hear the others.
Thank you very much. And I have one quick question, technical question.
Yes.
What is the number of the sample?
It's, I think, okay, so here it is. It's 431 adolescent girls from
age groups,
age 16 to 19 years old, and young women age 20 to 24 years old.
Okay. And
in 6 communities.
What the questions around bodily rights, which questionnaire did you use?
We developed a questionnaire that we used at the regional level, also in other Oxfam countries, but we of course followed some standards set not only by UNFPA, but also other actors in the field that I can share with you. I'm not very well informed about the metrics.
Excellent. Thank you. Any implementation of the results? Are these going towards some place to be implemented at the level of?
This study specifically informed the programs of Oxfam, mostly, and partners to a certain extent. So, and we tailored both the Masaruna and also the Power to Truth projects to respond to those findings. But I can say that in the project designs, we have planned for service provision because we are very well aware about the multi-layered crisis, and the extent to which it puts extra burdens on access to rights and not only services. But we also do safe spaces, dialogue, education, support to youth and women champions to lead on their own initiatives, support to all types of spaces, including the digital space, also besides the physical and moral spaces and so on. We have designed pretty, comprehensive projects and trying to involve grassroots in the implementation. So we plan to involve or to provide 16 sub-grants to 16 local initiatives from Lebanon that all aim at advancing sexual rights in different ways. Their way. Mostly.
Much better than all the politicians of Tripoli.
Yeah, hopefully.
Bravo.
Yes, so that's about the project.
Thank you, Ms. Malouk. Any questions to Ms. Malouk on the presentation? Okay. Thank you.
Thank you.
I'm glad to invite Ms. Khawla Bouaziz. Khawla is a young feminist, queer rights advocate from Tunisia. She's been working directly with LGBTIQO+ in Tunisia for the past 4 years. Currently, she is the Secretary General of the initiative Mawjoudeen. We exist for equality in Tunisia, and is leading projects on research focusing on LGBTIQ+ people demography in the country, as well as sexual reproductive health rights of the LGBTIQ+ community. Khawla hopes to emphasize youth-focused approaches in the work that she does, which fits very well under the ongoing research, whether under Asfari or by Oxfam in Tripoli, to aim to create youth-led, youth-centered work from the youth to the youth. Floor is yours.
Hi. Hello, everyone. Thank you for coming here today. Just a small clarification. I am no longer the Secretary General of Mawjoudeen, just to clear that out. Okay, so as Dr. Faysal was introducing, most of my work has been centered on evidence-based international advocacy for LGBTIQ plus people. That means that I do a lot of work on the ground, listening to the issues, tackling different kinds of traumas, and also being in touch with the legal framework, specifically in Tunisia. So today I want to focus mostly on what it means to provide sexual reproductive health rights for queer people, and why this particularity of our issues as queer people is very important in conversations like these. Well, first of all, the first fact that we need to start with is that Tunisia, for example, criminalizes same-sex relationships for 3 years. Lebanon does too. Egypt does. Iraq doesn't on text, but punishes it. So basically, we're a region that criminalizes the existence of a whole group of people. So when we talk about accessing SRHR for the queer community, we cannot talk about it like any other community, because first and foremost, there's a legal barrier. Any queer person who is just going about their day, going, for example, to any service, healthcare service, they risk a big threat to their lives just by going. So that's the number one issue. Sorry. But further than that, when we talk about the healthcare providers, healthcare institutions, these institutions and these people themselves are not educated enough in the issues of LGBTIQ plus people. There is no understanding of what gender identities and sexual orientations play into the situation of SRHR. There is no understanding of queer bodies and the needs of queer bodies. There is no understanding of how STIs are transmitted between queer people specifically. There is no knowledge, or at least enough data, to talk about the extent of STIs and other sexually transmitted diseases within queer communities. Most of the issues that the queer community had the spotlight on for decades are basically HIV, and that's it. This has been the agenda for decades. Between the West and the East, it's not just a global North problem, it's also in the global South. So to talk about queer issues and about queer body autonomy as a step further than just HIV and just medical biological issues is itself a hurdle that we need to overcome first, to then reach out to more issues about SRHR. So that is a very important thing to note, because as long as we do not regard queer people as individuals who also have as much bodily autonomy as anyone else in society, and have much more issues than just HIV and STIs, then we will not be able to advance much. So that's the very umbrella of things. To go even further, I think everyone here in this room knows that we cannot talk about SRHR if we're not talking about economic inclusion. And queer people suffer from the lack of economic inclusion on all levels. It is a domino effect, because most queer people suffer through education, starting from basic years of education, go into higher education, go into post-graduate education. All of the parkour of queer people is riddled with difficulties, whether it be discrimination, lack of access to funds, lack of access to family support, to friendship support, to partnerships. So it is already a hard road, which means the chances of economic inclusion are already limited. Not only are they not able to access these spaces, but even when they access these spaces, they are most likely to face discrimination. There are no laws protecting their rights as laborers. There are no not only no labor rights, but also no rights in general. As I said in the beginning, being criminalized means that you have to hide your identity in the workplace. And as you can imagine, that leads to a lot of psychological and physical issues and repercussions. So how can we expect a community that is already in economic disparity, legally unrecognized, and already stigmatized with issues like HIV and STIs to access their SRHR? When we talk about the community, we go a step further than just inclusion, than just access to healthcare in its basic form. Here we're talking about a whole umbrella of stigmas, of shame that has followed the community for decades. And even in realities that are moderately doing well. And here I'll take the example of Tunis, for example. In Tunisia, the ONFP, which is the National Office for Family Planning, we have centers for SRHR. We have access to abortions, free, anonymous, and open for everyone. We have access to contraceptive pills. We have access to all these things that many other countries are still fighting for, but that is for cis straight people. It is not inclusive of queer people. We've had a lot of conversations with my work and my colleagues, with people working in the ONFP, and we asked them, what do you do to make sure you're inclusive of everyone? Most of the time, the response is, we don't care about their gender identity or sexual orientation. They're welcome whatever they are. The sentiment is nice, but the application is not, because you should care. You need to care that the person who's coming seeking healthcare is a lesbian woman, not a straight woman. That means a whole other set of issues that a straight woman might not have. It is important that you care that the person that's coming to you is a transgender person, because the treatments, the parkour, the whole lifestyle of a trans person is different from a cis person's. So even though the sentiment is good and they're trying not to be as discriminatory as other public healthcare sectors, there is still a huge gap in education and in knowledge about the community. And as much as civil society organizations are trying to educate people, to reach out to these centers, to make sure that the information is spread, it is still not enough, because obviously CSOs cannot substitute the role of government when it comes to issues like this. I wanted to present you with a few statistics that we gathered in our latest report, LGBT assess the socioeconomic situation of queer people in Tunisia. The report is available online if you want to check it. So in these statistics, we found that 50% of the lesbian women we interviewed said that they never used protection. They don't know what protection looks like for them with relationships with women. 73% of all the interviewees never tested for an STI. 73%. 33% of everyone interviewed doesn't have insurance, no form of insurance, so they cannot access not public nor private healthcare. And 75% of trans people interviewed said that they faced some form of violence within healthcare institutions. As you can see, these are pretty shocking big numbers, but it makes sense, because even within the community itself, women are not given as much attention to their issues as men. Even the disparity and that dynamic exists within the community. Gay men typically have more access than lesbian women, for example. And cis queer people have more access than trans queer people. So the issue is even deeper when we look inside the community itself. And when we talk about sexual violence, when we talk about violation of bodily autonomy, sorry, when we talk about these issues, we often find that within the community itself, people are silenced about these issues. The stigma that follows queer women, for example, makes it really difficult for them to seek any type of justice. The stigma that surrounds gay men especially within the police force and the judicial institutions, at least in Tunisia, it makes it extremely difficult for them to seek any sort of justice when their bodies are violated. And even worse than that are the communities that are not recognized at all, like trans people and intersex people. There is no mention in any legal document in Tunisia, for example, about trans and intersex identities. They are not legally recognized. So what do you do when you want to talk about the sexual reproductive health rights of a community that's not even recognized in your country? How do you access information? How do you collect data? How do you do advocacy for them? It is really difficult. And oftentimes we find ourselves in situations where we need to come under the umbrella of feminist movements, of youth movements. It works, yes, but at the same time, it is not enough, and it pushes the core issue of queerness aside, which should stand on itself, regardless of what movement it's working under, basically. So not to make this much longer, but my recommendations or my most pertinent observations would be that, first of all, there will be no full SRHR for queer people without decriminalization. There is no way that could be achieved. As long as you're criminalizing the identity, the body, the access to any sort of public institution for a whole community, that community will not be able to obtain its full rights. Also, there is no ground for SRHR for queer people without public awareness, public conversation. People need to be aware, need to know that their attractions, their preferences, the way their bodies are formed, the way their bodies transform is normal and is okay. That should be communicated. Young people need to have access to information, especially communities such as trans and intersex people who go through a lot of body perception issues and lack of understanding of their own identities throughout their whole life, with no resources that will guide them and no role models within their own communities that can tell them that they're fine and they're okay, and this is just part of the process. And finally, we need to be aware and work on changing the whole legal framework surrounding queer people and minority groups in general. Because as long as we're violating the bodily autonomy of someone, we cannot talk about their sexual reproductive health rights. That's the number one pillar before we talk about anything else: contraceptions, abortions, healthcare, inclusion, equality. None of that matters if we're not setting an inclusive legal framework that does not violate the bodily autonomy of the community. Thank you.
Great. Thank you very much for this interesting and a little bit sad presentation. I'm gonna allow some questions for Khawla, because Khawla has to leave immediately, as I understood, for another commitment. Any questions to Khawla? I have a question, 2 questions. You spoke about the sentiments, and rightly so, of some of the healthcare providers in Tunisia, and you said that might not be enough, and I agree, because it's not something which is legal in a legal framework, in a policy. But do you see any chance of building on these sentiments towards increasing tolerance of this important community, of the queer community? Question one. And then from there, do you see any windows of opportunities that you can use? You mentioned something around the feminist or the other activist organizations, to start there and then probably expand vis-a-vis lobbying / advocacy.
So concerning the first question about healthcare workers, yes, I do believe there is ground for improvement, especially that institutions such as the UNFPA are cooperating with us. They do work with us. We do meet, we do talk about these issues. So that is already something very important and very good for us. Obviously, we cannot be oblivious to the reality that not all of their offices are as open-minded, not all of their offices are in conversation with us. And unfortunately, Tunisia shares the reality of the region of corrupt bureaucracy. So all the work that we try to do higher up with the executive branches of the UNFPA is stalling and has been stalling for a while now, especially with the current political situation. So we find ourselves trying to do double the work on the ground and higher up at the same time, and hopefully we get somewhere. But the grounds for improvement are there. And even if not with the UNFPA specifically, NGOs more and more are providing testing, information, trainings, workshops all around the sexual and reproductive health rights of queer people. It is just really, I don't know what's the word to use, but let's say frustrating to see that it's always reliant on NGO initiatives. We do not find a lot of initiative from any other sources. And that is really lacking, and it's really important because NGOs cannot do all the work. And here I speak specifically about some regions where we do not even have access to. As queer organizations, it is not very easy for us to go inside regions that are more conservative, that will not welcome us, will not give us space or time or energy to do the work that we do. And we do not want to risk it either for the safety of ourselves and our members. So we cannot access those regions. And the only way so far that we've been relying on to access those regions is, leading up to your second question, cooperation with other organizations that are already established and accepted in other regions. So these could be youth groups, they could be feminist groups, development groups, really any type of organization that already has established roots in these regions. So we try to work with them to include some of our issues in their programs and vice versa. So we either train them or they train us, etc. So that is some of the work that's being done in order to reach as many people as possible.
If you want to excuse yourself, feel free. I'm not giving you permission, I'm just telling you, making it easy for you. I'm glad to introduce our third panelist from Egypt, Ms. Suhaila Al-Fakihani. Suhaila is an Egyptian social researcher and anthropologist, currently part of some research work for the CRTDA. Suhaila holds an MA in social anthropology and works in research development and advocacy, with the main areas of research are state-society relations. You can imagine this in Egypt. Public health, youth, sexual and reproductive health and rights, intersectional feminism, structural violence and gender-based inequality, mental health, and precarity. She believes that the merge between the two analytical tools, the theoretical and the field work, enhances analysis of social inequalities as lived experiences. And I'm I agree.
Hi, everyone.
Thank you.
Hi, everyone. Sadly, echoing all of my colleagues that spoke today, all of those inequalities are echoed in the Egyptian society and experienced every day by Egyptian citizens. Even though Egypt has signed multiple international and national obligations, such as the CEDAW, the CRC, the ICPD, and even submits voluntary reports for the SDGs, it fails to include major problems and concerns that the citizens of its country face. When it comes to the SDGs, the Egyptian government has created the Egypt Vision 2030, which adopts most of the goals that are in the SDGs and has utilized, it was supposed to utilize the Ministry of Health, the Ministry of Education, and Ministry of Social Solidarity in order to enhance the capacity of gender inclusion as one of its main or cornerstone issues. That being said, the health strategy and the population strategies of 2015-2030 have not really tackled any major issues except for family planning, child marriage, and FGM, leaving other concerns unattended to. The conservative approach Egypt has for SRHR and its main focus being on family planning ends up creating this lack of transparency when it comes to both the public and the private healthcare systems. There's a rhizomatic relationship between the culture and structural violence, which exists on the ground in most of the countries we talked about today. And it creates direct limitations to the accessibility and availability of the knowledge and the services. It's not only an issue of which services should we go to or who is the doctor we're supposed to seek, it's also where to get information from. And sadly, the report we've conducted for Masaruna on Egypt, it tackled youth from 18 to 35, and it showed that most youth almost depend solely or exclusively on the internet for information about their body, which has its negative connotations in and of itself, because they either end up self-diagnosing, which is misdiagnosed, or they end up going to their peers for information who are also misguided most of the time because they have the same access of no comprehensive sexual education whatsoever. I want to take us through the findings of the research because it also had focus groups with non-heteronormative individuals, females and males. The key findings showed that the social and cultural prevalence of shame and taboo, it kind of derails any efforts that is on the ground to move beyond the aib stigma. The aib stigma still echoes in every single interaction a woman or a man has with the healthcare system, especially if they're non-married or not about to get married. There's no systematic procedure of any service or resource. You don't have a clear diagnosis, treatment, follow-up structure or protocol that kind of secures the quality of the patient, of the patient's treatment. And back to safe spaces, as Eliana highlighted, safe spaces was one of the biggest themes we've had on the ground because patient confidentiality is most likely than not breached. And sometimes they reach out to the family, they sometimes reach out to the partner, they sometimes reach out to people who could actually harm the woman or the man being treated in their facilities. In a nutshell, the whole ecosystem does not provide sufficient information or services for the concerns that are being on the ground, but I kind of boiled them down to four main things, and their healthcare services, concerns, sources and access, and further inequalities, including violence against women and violence against non-heteronormative individuals. There's a huge gap between the public healthcare system and the private healthcare system. If you're not paying enough in Egypt, you kind of don't get a quality service whatsoever. And the problem we have is that even private healthcare is still tainted by social culture and taboo. The social and cultural norms frame non-married women and non-married men as non-beneficiaries of sexual and reproductive health services. They just think they don't need them. Why would they need them if they're not about to get married? They don't take into account things like yeast infections, polycystic ovary syndrome, erectile dysfunction, so many issues and themes that can be covered within a non-married life or an abstinent life. But they still go undiagnosed and live their lives with all of these untreated illnesses just because they can't visit a doctor's office without being married. The patient confidentiality breaching is also a major issue when it comes to non-heteronormative individuals. And it was highlighted by the participants that it's a game of luck. You might go to a healthcare provider that actually helps you, and you might go and they can kick you out. And being kicked out of doctor's office has been echoed in multiple voices that we've heard, which is honestly not only limiting, but it's also scary. It's a very dangerous place to be if you're having a health anxiety moment and you want to make sure that you're okay, and then you go and you take the step and you pay to go visit a doctor that is most likely than not expensive. And then they tell you, sorry, I can't treat you. We don't treat any set. We don't treat non-married women. Another quote that I'd like to add here is that the lack of information about the body is major in the Egyptian context, whether you're educated or not, whether you come from an upper social class, from a lower social class. It's kind of across gender, across class. It does not leave anyone behind. The violence when it comes to the lack of any clear or coherent sexual education led to one of my interlocutors telling me, when I first got my period, I thought I died. No one had ever told her that she's going to be bleeding. No one had ever told her anything about her menstruation or menstrual cycle. So she woke up, she got her period and went to her mother telling her, Mom, I died. That was her encounter with something she's going to live with for a majority of her lifetime. She's going to be going through menstruation every month for 30 years to come at least. The females also in the study showed that the sexual and reproductive health and rights pertains to different stages of their lives. They need this guidance throughout their trajectory. They need this guidance from teenage years, even before that, until they become adults, and then when they're married, and then after even marriage, their whole trajectory is kind of silenced most of the time. And then moving on to sources and access. Access to ethical and reliable resources and sources is the biggest issue when it comes to sexual and reproductive health and rights in Egypt. Schools do not offer appropriate or in-depth sexual or reproductive health education, as it has been mentioned before by some of the countries that in the Egyptian context, it's heavily biological, and when it's biological, it's sometimes skipped if the teacher is too ashamed to discuss the topic, as is my own experience in an international school that is expensive, that is high-end, that is everything. The teacher was like, this is something to read at home. We're not going to discuss this. So being left with no talk from the family, no sex talk. We actually have the no sex talk, do not have sex talk, not a sex talk where you can understand your body, with the country being led by an educational system that has no space for sexual and reproductive health, and then moving beyond to seeking healthcare from the facilities that offer them, and then being shut down if you're not within a marital status or a gender status that allows you to be there, creates a limitation where people just find themselves on a screen looking for help, and most likely they're not create further health anxieties. Another big issue that we can't really unsee on the Egyptian, in the Egyptian society is pornography. Egypt is one of the 5 most viewing pornography countries in the world. And the messages that come across in those scenes and in those sources kind of create this not only idealistic images of the body and what a woman should look like and what a man should look like, but also how the relationship should be. And most likely than not, we know that the industry of pornography will also lead to normalizing violence and normalizing things that are supposed to be a partner and the other partner's choice of whether or not they want to exercise it. But at the end of the day, the normalization of it creates further inequalities and further violence. I'm going to go very briefly, I'm just going to cover very briefly violence against women, because FGM is a huge issue in Egypt and it pertains to so many people and so many women that it's scary. When you hear the number 86% in 2022, after the eradication of FGM committee and the National Council for Women's Efforts and so many things we see happening, but the cultural and social ideas of controlling women's bodies and their sexuality and their desire by mutilating their bodies is still very, very much exercised in the Egyptian context. I'd also like to add that unfortunately, sexual harassment is a major issue in Egypt as well. Sexual harassment has been noted down and has been legally a crime since last year. But before that, it was not even defined by the law what is sexual harassment and when and how can we criminalize it. But the prominent gender-based violence issues against women are FGM, child marriage, verbal and sexual harassment, coercion, domestic violence, physical, emotional, and psychological punishment, and discrimination based on gender or sexuality. We cannot really also unsee poverty. Poverty being a huge issue that looks that takes us to the issue of intersectional feminism. Growing up female in Egypt is hard, but growing up poor and female in Egypt is even harder. At the end of the day, if you don't have access to private healthcare, you kind of don't have access to quality healthcare, that, like we just said. But also, we still have an issue with lack of sanitation, lack of hygiene, lack of period related issues and bodily related issues that we kind of label as period poverty. Moving on to issues of violence against non-heteronormativity, I'm going to start also by a quote from one of the interlocutors who I was interviewing about testing. And I was just asking, what was your experience like? What did you go through? And he's like, when we go there, you have to act masculine. You have to wear clothes that don't make you feel the way you normally feel. You have to be very masculine. You have to kind of have the voice of the macho man. And if they ask you why you're testing, you have to say it's for drugs. So the quote was, they'd rather have us die from drugs than be gay. And that was very moving for me. That's just a moment where I was like, that's every day. That's literally their every day. And although STDs and STIs are one of the biggest concerns to this community, there is no available knowledge on protection as voiced by the participants. There are no clear available protection medications for HIV and HPV. For example, PrEP. There's also no available emergency medication that's widely available, which is PEP. Moving beyond this research, just talking to my friends from the community, they just told me that now PrEP and PEP are like drugs. People get them from abroad for 20 euros and sell them for 3,000 Egyptian pounds, which is 10 times the price. For now, dealing with the whole issues of sexuality and the whole issues that are heavily medical and heavily burdening to the person going through them as something that they need to cover, that's something they need to even buy medication from like an illegal source that you don't even know what you're taking. You might be taking a placebo and just tell yourself, yes, I'm on the medication, I'm good. It was also mentioned that according to an HIV positive Egyptian person, that the healthcare system and its providers would rather have us risk our lives than just enjoy our sexuality and be alive. Echoing Dr. Faysal again, I honestly don't know where our recommendations are going to take us. It's a very hard place to be. The underlying emotion throughout the whole sessions that we went through and the whole focus groups and the interviews with key informants, there was a sense of pessimism with some hopefulness towards the current SRHR ecosystem in Egypt. The female youth focus group discussion, it was extremely disheartened, and by the time we were asking them to propose potential solutions or fruitful recommendations they may have, not a lot was said, given that the discrepancy that already exists between what is in place and what is operational, successful, and plausible is non-existent. It's very unfortunate that when you go to ask someone about their hopes, like, tell me, what would you like to see on the ground, and we'll try to make it possible. Let me know how I can help you. Let me know what we can put out there for the world to see as your own recommendation for when you were 15 growing up. What would you like to hear? What would you like to know? The answers were always like, yes, education, maybe. We don't know, they won't allow it, they won't allow it, they won't allow it. And the idea of allowance has been a huge issue, because even though the media uses all of its power to propagate things like itnin kifaya or haqq tnazzami or things like that, and then we boil it down to the ecosystem of the whole country and the economic flourishing or not, and lack thereof is dependent on whether or not you get this child, it ends up creating a place where you feel responsible for something you're not supposed to be responsible for. So in very briefly, the summary of the recommendations are, because in Egypt, every person, not even organization, every powerful person has their own cultural and structural issues that they kind of give to us to deal with. The messages are very different. The NGO messages are very different from the governmental messages, are very different than the state-led initiatives, are very different than the media campaigns that we see. So unifying the messages and guidelines that are different, that are used by different stakeholders, including the civil society and NGOs, was one of the biggest issues. Providing safe spaces and patient confidentiality, ensuring changes in mindset of healthcare professionals and doctors, increasing social and cultural awareness, increasing sex education courses and knowledge in school, universities, and institutions from an early age, improving access to sexual and reproductive health rights and services in the public areas and spaces. And the one that I'm actually hoping for is utilizing the media and creating media campaigns that are culturally and socially sensitive. Because at the end of the day, if we're having this immense sensitivity, it's like an electric shock for the system when you talk about sexual and reproductive rights, we need to do it through it. We need to find a way out through the system in order to beat it. Because if we just say, okay, we're rebels, we're just going to go out there, we're just going to be imprisoned. It's as easy as that. Unfortunately, the role of civil society organizations and NGOs is very weakened at the moment because they're heavily surveyed. When we interviewed a couple of NGO founders, they just said, back in the day, we had the space, but now we have no space. And we can't even use the word sexual in our disseminating events. The word sexual is not to be used. It's either development, family planning, or reproductive health, and it depends on the outlet you're putting it on. So facilitating volunteer activism for those who are willing and able to participate in the sexual and reproductive health and rights field as researchers, volunteers, content creators, or as experts in the field is major. And I think this can be done by having digital platforms that brings those voices together, not only in the Egyptian context, but also in the Arab region as a whole, because I feel like when we're all scared of being frowned upon or being called names and being put in this frame of people who are trying to break the system and create this AUB movement, coming together is key because it strengthens us. It just gives us more room and voice to do those things with no fear, because you're going to feel the fear, but you need to do it anyways. That's that. Thank you.
Thank you. Thank you, Sohaila. Any questions for Sohaila? Yes, please.
Yes, please.
Thank you. Very interesting. Based on the last point that you mentioned, how do you really navigate between pushing the boundaries, or what's the thin line that you follow to push the boundaries, but at the same time be culturally sensitive in a topic that is sensitive eventually and that we want to push forward? So how do you practically translate this into action?
For example, one of the things I came up with, we see media campaigns all of the time. Egypt is going through a very intense economic and inflation and issues that have to do with the socioeconomic nature of things. But we still have media, and we still have series, and we still have ads, and we still have very big bridges that are all over Cairo right now, at least. For me, the example was a media campaign where there's, for example, a teacher in a classroom giving very biological facts to kids, and then this kid grows up, and then the same teacher is giving the next level of sexual and reproductive health and rights knowledge. And then this person, for example, is about to get married, and then the knowledge is also transferred in this sense. And it's going to be very culturally sensitive because it's a knowledge-based thing, and it's going to start with biology and then end with things like consent, boundaries, how to stay safe, being in a healthy relationship, all of the aspects that we kind of know we need, but we don't know where to look for.
Other questions? Thank you, Sohaila. I have one quick question. If you look at the differential of the various actors in Egypt, do you see like there are agencies that are more willing to take issues further in terms of SRHR, or it's a factor of the overall agency's performance? To get my point.
Depends on which part of SRHR. If we're talking family planning, if we're talking knowledge for women who are married, if we're talking villages and information, there is work there. But if you're talking non-heteronormative relationships, there's nothing. You cannot even mention it in reports that are being published from Egypt. No way. And if you're talking non-marital relationships, no way. If you're talking about things like bodily autonomy or the woman having the right to abortion, for example, is still illegal in Egypt, except if you have a major medical issue and if you're married, of course. But it depends on which route you're taking. The point in Egypt is that the discrepancies are so widely obvious that you can't unsee them. And we propagate so much of our government now is about this is the time for women. We're a government for women, the National Council for Women. But where do women even lie? Where do poor women lie? We have no idea. Where do women with money but no access to quality private healthcare service providers that are not going to call them names or kick them out because they're non-married and they want help? Nothing. But it depends on the sexual and reproductive health and rights aspect you're looking at. But the things that are still taboo and shame are still taboo and shame. But if you do it through population development, family planning, if you're still in line with Egypt Vision 2030, يمشي.
I know that in Egypt, you even need an approval on the methodology you set for any research, right? And you need to have a report reviewed before it's published. So I'm impressed by the way you could actually look into these demographics and generate these findings, because in our case, we are in Egypt, but we are in Egypt undercover because we're not allowed to discuss many of the topics of concern openly in Egypt. So maybe at some point you would share with us, if that's in any way possible, you know, about the way out you have established for yourself, your organization, your team, to actually look into these matters, you know, without affording the burdens of the shrinking civic space around, you know, the activities of groups and civil society organizations concerned about these topics specifically.
Just a very quick answer. It's just very unfortunate that you kind of have to play the system to beat it. What we do is we just generate very, very normal IRB processes, and we come up with questionnaires that we always say are modifiable, and we just say we're interviewing humans, age range, but no gender specifics, for example. We played by ear, and both to a huge extent, that's why I'm working with CRTDA. That's why I did it under the Masaruna project and Oxfam. You kind of have to secure yourself in a way. And I still wait for the day where they will just wake up and see something that I wrote somewhere and call me. Yes.
Oh, okay. So this has been something that I've been thinking about throughout like all the panel speakers. So there is the idea of legality and the fact that all of this isn't legal, but there's also the idea that these demographics are really afraid probably of just working with you or even answering the questions that you have or like the services. So how do you kind of maneuver that in a space that's very traditional and closed off? Like when I think beyond the capital here, if we go more south, it's very hard to just tell these people that I'm a safe space. You can come get this information from me. So how do you maneuver that practically?
The beauty of anthropology is that you kind of have to build rapport. So you go to those people and you just build a relationship with them that's outside of the research. You talk to them with no record, with nothing. You just spend as much time as you can with them. And what you also do is we seek NGOs helps NGOs help. We go to founders, we go to people who are project managers, and we tell them, for example, we're doing this, this, and that, and we'd like your help, مثلا, to find us interlocutors. But for them to actually speak to us, you need to build this relationship beforehand, and then you need to sit with them and silently observe what's going on, and then you sometimes interact, and then maybe a couple of interactions later you tell them, I have a couple of questions for you if you don't mind. And anonymity is key. Anonymity is the biggest thing we do. For example, all of the non-heteronormative focus group discussions were signed by pseudonyms. We're not going to tell anyone who we are and what we're doing, but let's talk. And it's fascinating how humans like to talk and share their experiences. Like sometimes it just amazes me. We just met and you just told me all of your traumas, for example, and I'm just sitting there humbled with the information they're giving me. But at the end of the day, when you have zero space, when you give them the space, they actually talk.
We had to hire youth to speak to youth, right? So these are their friends. These are other peers that they know about, that they trust, that they know that they share their concerns and issues. So it cannot just be the standard, typical, research approach that we can adopt in any research or in any study when we discuss culturally sensitive topics. And hence, we need to accommodate, we need to allow it more times, we need to be very flexible in terms of timeline, resources, designs, approaches, and so on. And this is where we also call on donors and then practitioners to actually account for these considerations, because you never know how you would need to navigate any situation you suddenly find yourself in when it comes to discussing culturally sensitive topics, including security approvals in the case of Egypt, for instance, surveillance and then other censorship matters. So yeah, it's very delicate, I would say.
عايشك برشا. So, as we all know that Tunisia is considered to be pioneer in women's rights and states in the MENA region. So it has been independent since 1956. So advanced when it comes to reproductive and sexual rights. It has always incorporated women in the development and policy agenda. So I will explore the extent to which reproductive rights have been incorporated into the country's reproductive health policy and the influence of this policy on gender empowerment. So Tunisia took vastly different approach to women's sexual and reproductive health rights. It's an emerging democracy with a long history to top-down women's rights advance and state-promoted SRHR. Tunisia women have benefits from SRH education, access to contraception, emergency contraception, and state-funded first trimester abortion. Tunisia target also vulnerable population, including unmarried, minor, rural, and poor women with special clinic and subsidies. So it holds also men responsible for children they birth outside of wedlock. It's all benefits and about and causes of the International Conference on Population and Development Market, an important transition in Tunisia population policy. As it led the country to abandon and focus on purely demographic concern and instead embrace reproductive health as a priority part in national health program. We also know over the past 10 years, Tunisia has gone through a policy transition marked by the new aspiration of democracy and respect for human rights. Throughout this period, women's rights, including their sexual and reproductive rights, were among the most discussion topic in the new republic. However, according to the Shadow Republic submitted the CEDAW commitment by the Association of Democratic Women in Tunisia, women are subjected to numerous violation of their sexual and reproductive health, including discrimination against unmarried women, virginity testing, and as Khawla, she said, criminalization of homosexuality. So we need to talk and know about the incorporation of reproductive rights into the policy. So about the promulgation laws that protect reproductive rights I'm sorry, I'm a little nervous. I'm stressed. Thank you. Okay. So promulgating law that protected reproductive rights constituted the first step toward the integration of this right into reproductive health policy, as this law presents the legal framework for the formulation of strategy and program related to reproductive health. In Tunisia, the right to use contraception and the right to abortion have been protected under law since 1961 and 1973. The right to reproductive health has been incorporated through the guarantee of service possession in various nation health programs. Free access to contraception, abortion, and counseling for all women in ensuring throughout the country's family planning program. So, for example, I take the abortion that was made legal for women with 5 or more living child. We talk about since 1965. This policy, it was soon rewritten, and the new abortion law, which is still used nowadays, was legalized since 1973. So the new law permitted abortion within the first 3 months, provided in a subtle facility free of charge if women were eligible for free healthcare. After Tunisia, Women's United Generation public and government pressure caused by multiple suicide due to pregnancy outside marriage, abortion became not only a law among all married and unmarried women, but policy accepted it in order to control population and boost social economic development. Also in Tunisia, religiosity played the most significant role when talk about abortion rights, even through the procedure in legalization. After the Jasmine Revolution, we all know Nahda majority influenced reproductive and sexual health through religion discourse that aimed to replace national with nursed mores. Abortion denied within the legal setting or during Holy Ramadan, women being denied of procedure because of personal physicals. So it benefits and issue due to complicated democracy were causes in the time of Nahda movement party. Level of abortion this after Arabic Spring reduced. This doesn't come as a surprise as religiosity is strong associated with less progressive abortion law. So the liberalization of abortion greater rights to contraception and the promotion of women's states within the family present important step in women's empowerment. So we have the problem of regional inequalities. Women access to reproductive health care are further reflected in women's reproductive health indicator, such as maternal mortality ratio. Women's reproductive health and rights are affected by the social organization of gender relation. Gender inequality is responsible for women's vulnerable state and limit their ability to make free decisions about their bodies and their life. It also leads to harmful practices such as gender-based violence, which can affect women's health. Gender and women rights, including reproductive rights, are inextricably linked. For example, the right to have control over and to make free decision about reproductive and reproduction health. Women cannot enjoy this right if they are economical dependent or policy included. Education is also cruel for improving women's knowledge about the availability of reproductive health service and for ensuring their access of this service. Moreover, gender empowerment improves women's economic and social states. This created a positive environment in which they can claim their rights. Examining the state of gender equality, it is therefore critical to understand the environment that shapes women's capacity to exercise their rights. So such practices affect primarily in married women. According to the Family Health Survey conducted by the National Board of Family and Population in 2018, health workers considering spousal consent a normal precondition for providing contraception to women, even though no official instruction justifying this practice exists. So bravely, I'm sorry. So gender empowerment requires that government adopt effective intervention around gender equality. Tunisia commitment to Beijing Declaration and platform for action means that is mainstream gender. It's in all policy and program as part of strategy appreciate to achieve gender equality. Throughout, Tunisia has begun to do this recent years through the creation of gender focus point in ministry. The mission of this focal points have yet to be defined. So this in general.
Thank you.
Thank you.
Thank you very much. Any questions for Rania? Okay. I have a question. Rania, do you think that Tunis being on the scale of the SRHR path in the region is probably ahead of many other countries because of the historic advancement on the women's rights and on the liberal rights in general, led by late President Bourguiba. Do you think that the early presence of women in the political sphere, in the public political sphere in Tunisia, is gonna facilitate the progress on the issues, the challenging issues that you have mentioned? And if this is the case, does what happened in the Arab Spring, so-called Arab Spring, have affected these attempts and this progress of the gains of women in the political and in the freedom fields?
We said in Arabic التعود أو adaptation. Yeah. التأقلم. عنا كلمة بالتونسي نقولوا تعودنا فحصل ما تنجمش ترجعنا.
وباللبنان كمان
تعودنا. ف with Bourguiba it's يعني if I can speak Arabic it's okay, thank you. It's okay, thank you. احنا في تونس تعودت المرأة انها تكون حرة مع مجلة الأحوال الشخصية. يعني بورقيبة عمل مجلة الأحوال الشخصية فأزال تعدد الزوجات، والمرأة لها حرية انها تتطلق او تحدد عدد الاطفال اللي هي عايزه تجيبهم. فكان يعني بعد الثوره او المشكله مع النهضه، لانها عايزه ترجع انه الدين هو القائم، فلازم 4 نسوان فكانت المراه لا، احنا هنا فيش تقول يعني
ما خسرناش يعني هيدا الانجاز.
يعني يستحيل انه نرجع لورا. فكان بالعكس احنا قاعدين نتقدموا الى انه المرأة ولات في القانون تختار الدين دين زوجها، او انها تتعامل مع زوجها بالمثل. يعني اصبح عندنا ظاهرة العنف ضد الرجالة، يعني اختلفت المفاهيم في تونس. فبالضرورة انه الصحة الإنجابية والجنسية في تونس يمكن في المناطق الريفية لأنه ما فماش access to وفما التأثير of economy، يعني فما تأثير، فيستحيل أنه يكون ترى.
But you are hopeful يعني.
Yeah, sure.
تفائل.
Yeah, sure.
شيهم بورقيبة أكبر نعمة
هي التغيير.
عامل بوليسي محترم. شايف ما بدك NGOs، إذا أنت government ماشي عم تعمل الشغل ما بتخبي ورا NGOs. Thank you, Rania. And our fifth panelist is Dr. Dilman Azad. First, we have to thank Dilman for traveling from Sweden, but at least for now she was there for some work. But Dr. Azad is in Kurdistan, Iraq. She is specialized in forensic medicine. Is the head of Committee on Age Estimation and a member of what is still there called the Hymen and Virginity Examination Committee. And as you can tell, she is very much involved in the issues around forensic violence and protection of young girls. She's also involved in the teaching at Holler Medical University. Holler is the Kurdish name, I think, of Erbil, no?
Holler, yes.
Holler Medical University, which is one of the good medical universities in the region.
Yes, the rank is good.
I know from my colleagues.
Yeah.
Thank you, Dr. Azad. Please go ahead.
Okay. Hello, everybody. However, I'm the last one. I know that you are all tired now. You hear about everything. I want to talk about the sexual health reproduction, which is a very, very important topic. According to my job in the field of the forensic department, I faced too much problem in my country. First of all, you didn't hear about the Kurdistan region before. Maybe it is on a side inside the Iraq. We have the Arabic side and the Kurdish side. This side, we have the same traditional behaviors of the Arabic people, some with some different things. But about the SRHR, we have a too much problem in my country, and we have a too much gap, and it's not well developed in my country. First of all, I will talk about the teenage. When the young girl, she didn't anything about her body. When she become at the time of the period, even the mother feel shameful to talk to her girl about the period. And it is a normal physiological thing. Sometime I faced a woman bring her girl to the committee of the examination for the hymen examination. She don't know that the blood is a period. She told me, doctor, please examine my girl, if she is virgin or not, because this blood is come out. So this is a disaster. The mother don't know about the period, and maybe she forget, and she bring her girl only for the examination of the virginity. And sometimes I face it, a woman bring her girl when she sees some clot with the blood of the menstruation, she bring the girl, see the virginity, maybe the hymen, it is go with this clot. So this idea and the bad situations of the sexual health reproduction is a type of the violence against the girl. And this commit, it is in the Iraq legal. And in the law, they mention that there should be a commit for the examination of the virginity. And in the virginity test, only we depend on the hymen. We don't depend on anything. And this one, it's not a scientific way. I face it too much girl killed only by this examination. And too much is survived because of this examination. So this is a types of the violence. In my country, I face it every day. 14 years old in this commit, I'm working, and I face too much violence against women in this one. And even sometimes there is doctor, bring her wife, he claims that she's not virgin, and he's doctor. Why? Because there is some traditional idea. It has been passed through the generation in a wrong way, in a wrong idea. And we have too much girl, they drink coffee. Why? Because the mother tells them that you lose your virginity. If you drink a coffee, and it is a very, very, yes, it's a very, it's not scientific or anything is related to the virginity. This commit we have in any other country. Now I'm living in the Sweden. I see 100 years different between the system in the Europe and our system, which is the disaster thing is in the Middle East happen. The another thing is I want to talk about it. We don't know anything about the sexual transmitted disease because the word of the sexual, just the word, they only think about this one, the relation between the man and woman. They don't think about other things. And if you talk about this word, that you talk about stigma things in the community. Now we have too much cases about the human papilloma virus and transmitted between the pupil and the vaginal ward. It's too much. Even they make a research about it, but you know that in the Middle East, we don't talk about these things. And it is only shameful for the woman. If the man have this one, they don't talk about this one. Only the woman. It is the source of the transmission. The other thing is we have the mutilation in my country. Even we are in this century, but the mutilation still we have. The last research, my colleague did it in the Hawler city. It is about 60% woman percentage, they mutilated. And it is a very big percentage. And they don't know about the complications of the mutilation. They think that it is the right, and when the girl is born, they must do the mutilation for her. They don't think about the complication of this one. Also, we have another thing which is the marital age. We have the girl, they married is very young, maybe 9 years old, 10 years old, they married. We are in the age estimation commit. The mother come and they told you to make the girl grow. For the age, we change the age for her. If we didn't do this, they go to the political side and they make 318 for you and until you change the decision all that this girl, it's okay for the merit.
They lie about the girl's age.
Yes, they make it 18 years old according to the law to marry this one, and they didn't know about they don't know about the complications of this early, and she is not physiologically ready for the pregnancy, for the anything, even the behavior. It's not ready for her. About the recommendations for the solving all of this problem in the country, the first thing is the education. The education, social educations, even the making a conference, workshop, anything for the mother, for the father, for anybody in the community to behold it in this education, social education. And even making a program of the education and puttings, and we can teach the child from the kindergarten until they grow that there is a sexual health reproduction. And it is not limited only between the relation between the man and the woman. So it is a huge and wide, broad word. We can talk about it. And since 3 years ago, I did something is I put a page for myself on the social media, and I talk about these things. This is I faced it too much problem, and they call my family, my husband, that stop your wife to don't talk about these things on the social media. It's a stigma. It's a shameful. Now with the time, these 3 years help the people to understand little about it, little, not too much, but I am continuous about it. So everybody from his side, according to his professionality, he can help the social. It's not important to only making a program or anything. I'm alone. Only in my page, I can reach thousands of the people, and I teach them that the hymen is not a virginity, and the underage marriage, it's not a good, and the sexual abuse, what is the sexual abuse, and how you protect your child, and how you bring it to the medical department. I can use these things, and I can help little by little in my community. And thank you.
Thank you very much, and God help you. You have a lot of challenges, and all the best. Do you have any questions for Dr. Azad?
Maybe a question on the Iraq context overall. I hope you can enlighten me a bit, but I know from a previous experience working in Iraq, in Kurdistan, on different topics, social cohesion and peace building, we used to bring youth from, different communities together, the Arabs, the Kurds, the Shahabian, different religious denominations, and so on. And they used to be really very vocal about the fact that they want to beat the social norms and be together in a safe space, in a conference, right? In a workshop. And then I remember very well in one of the conferences on their way out, when they were going back to their back home, they were actually very sad and disappointed. And some of them were really crying because they know that as soon as they are back to their lands, to their houses, they will lose whatever friendships, whatever new mindsets they have created for themselves. And that, again, is not because they don't have the awareness or the education or the knowledge. That's because of social norms. So you speak heavily about, we all speak heavily and are convinced about the importance of knowledge building and education. But do we really think and believe that with knowledge and awareness and better education, youth, adolescent girls, women will be in better places? I think that's our challenge as civil society organizations, feminist activists, healthcare service providers, to still believe and be reminded every time that it's really not only about awareness and and education for youth at this point in time, at least. It's pretty much again about social norms next to gaps in awareness and education, because youth, Iraqi youth really wanted to be in better places. You have many activists, local activists, right, and champions in Kurdistan that we all hear about and met, at some point, but they can change only a little about the context and the circumstances there, of course, not only because of the social norms, but also the overall political situation in the country. Just a quick reflection. So I'm not sure what you think, and if you can do much about social norms in Kurdistan or not, in your opinion.
As I told you, everybody can make challenge and make something for the society to be changed little. Even little, it is too much for us. When, I will give you a real example. When I talk about the hymen on the social media, and it is not all of the time you must see a blood, and it is not a sign of the virginity. One of the time I'm in the committee and I'm sitting, the father bring her girl and tell us examine her because the husband want to kill her. But I read your abstract on the page, and it's not important every time a girl see the blood. So I bring my girl and examine her. If she is virgin, I'll not give again to the husband. So this one, it is a good example that my sound reached to the society, and I saved the soul of this girl. So everybody can change little, even little, it's a good for us. But you know that this traditional idea, it has been passed down all of the generation, and need time, need work, need challenge. Maybe we face too much problem, but it's okay. It's our job.
Yes, please, Rita.
Dilman, did you face any governmental backlashes? Did any entity from the government, did they attack you? Do they send you threats, I can imagine, or?
Okay. The last case, a real case I faced she's a girl, 17 years old. She is abused by a big political man. And I didn't know this man, and I examined the girl, and I write my report that this girl is abused. When she go to the court, the phone, my mobile rang, and they told me you must change this report because yes, I face it. Later with the fight, they kill the girl. But they kill not to the political man. The family killed the girl because she lost the virginity. And they killed the girl. So this one is the last one. It's only from 2 months I faced this one. This happened.
Made everybody silent with the conclusion. So sad. Other questions?
No.
It's not about continue. This is not a mandate of the healthcare provider. This is something which is the society norms, not norms, the traditions came about.
But sometimes it's safe.
We don't.
Sometimes it's safe. Because before you kill the girl, maybe they think they bring. Saving life.
Yeah, but this is not. But this is not how public health operates. You have to go beyond this.
Social.
You don't have to wait. You have to go beyond this to provide data and evidence that there is nothing called hymen and there is nothing called virginity and there is nothing called testing about these things. This is all a made-up lie, made-up traditional construct, part of controlling women, that some people, like probably the mothers of those girls, they believe it and they want to protect. They think they are protective of their girls until they kill them. but then they are protective of the honor of their family. So I think that's where you have to deconstruct all this. And as they succeeded in many communities, they're going to succeed in Kurdistan. You have to think of the community in Kurdistan, Iraq, as a community that needs another lapse of time to achieve this. You know, look at us 50 years back. We have a lot of traditional similarities. They need time, and they need people like Dr. Delman and others to keep on voicing, lobbying, advocating, and it's going to change.
It would be just a bit interesting to listen to hear from the doctor about their context, in the sense that she was saying that sometimes it saves, and I think it would be interesting to know her experience about how she thinks that might be possible and the ways she thinks could work right now to lobby in Kurdistan or in Iraq.
Excuse me, I didn't get.
How do you think it is better to bring it to the doctor because you might save?
Okay,
how do you
because
see
before this
dynamics?
Before this commit, before we publish about this commit, anybody married and they didn't see this drop of the blood, they kill the woman directly. And they kill her and everything is disappear. Now they have some education that there is a commit and they bring the woman to the comment. Even they bring her in a bad way in violence, and it's a type of the violence, but it is save the life of this woman. So there is better and there is more better. This one is more better than kill her and everything is disappear. You know.
Thank you.
I have a personal question, not very personal, but like, did you ever feel you were in a position where you felt you wanted to lie about the result because you feared the life of the patient?
Yes, yesterday I talked with my colleague and I told them, yes, my father is judge. Every day told me, save the life of the girl and right virgin. Me, I applied this one. One of the cases, I applied, I tell the husband that your wife's virgin. When she came back, the girl told everything right about her relations with the previous to the husband. The husband make and go to the court and me go to the judge, to the court. I face too much problem. So sometimes I want to save, but we must protect ourselves also.
For sure, yeah.
Is there any final comment by the panelists? You would like to say something, like you forgot to mention something burning? Because the food outside is also burning.
I just want to give a closing remark that I forgot to say, but after the very highly intensely depressing moment we had, I think it's fair to say it. One of my favorite philosophies is the philosophy of becoming. And it's the idea referring to constant change opposing to being, which is the fact that humans as individuals are always in the process of becoming something else. And so are governments, and so are places, and so are everyday lives. I just want to close off with a quote by Beale and Locke from Unfinished Anthropology of Becoming. Indeed, the realities in which we are all entangled today and in which of becomings of our characters unfold are on the edge of financial collapse, infrastructural breakdowns and environmental calamity, racial violence, right-wing populism, and alarming new regimes of security and surveillance, and chronic warfare, mass migration, and deadly health disparities. In the meantime, people may find ways to endure the intolerable and struggle to repair and heal, untangle themselves from the known and establish new relations or not, negotiate threatening detours and the newly uncertain, and make use of these very realities to create viable forms of life and project themselves into a future, or simply remain in suspension amid the collapse of these structures. Yet, amid today's alarming global political shifts, it's also obvious that people's plasticity, shaped as much by fear and resentment as it is by hope and desire, carries destructive and violent potentials. Thank you.
Interesting.
Mutilation in my country, we have some talk about the mutilation. The old woman told the girl, إذا ما عملتي الختان الأكل اللي في إيدك يصير حرام. يعني أنت ما لازم تطبخي أكل وما لازم أحد يأكل من إيدك. يعني هذا traditional word يعني جيل ورا جيل ورثوها على إنه البنت اللي ما مسوية ختان ما لازم تطبخ بالبيت.
بس هدول
فهاي
these are easily should be easily eliminated. You know, these are now 2022, not even fairy tales. Even إيه بس كله بينشال هيدا.
بس والله صدقني دكتور أني شفت يعني من الطبقة الراقية ومن الطبقات المثقفة وناس عندهم أفكار كلها متحجرة.
هذه لا راقية ولا مثقفة، هذول أو معهم مصاري أو معهم شهادة.
أي صح. بس إيه معنى الثقافة مو معنى الشهادة. بس يعني دكاترة بيجيبوا زوجاتهم
دخيلك الدكاترة دخيلك أضرب
يعني هذا ديزاستر. يعني إذا ما يعرفون شيء عن الهايمن يعني ديزاستر.
I understand. بس إنه I suffer with them like you do. With this, we thank the 5 amazing panelists who came from Lebanon and from abroad. I want to thank, she doesn't like to call her Miss Rita Basil, but Rita Basil, for all the follow-up and the logistics and all the support. I want to thank Asfari Institute for hosting this amazing events, and my good friend, Lina Abu Habib, who couldn't be with us because she is in the US. I want to thank the team, sound, audiovisual, and all the other people involved in making this event a success. Thank you very much.